Hello, everybody. Welcome to our next episode of TPG, the Physician's Garage. I believe today is part two of Rounding with Dr. Bayes. And I'm Vineet Turavati. I'm a fourth-year medical student down at Emory in Atlanta, Georgia. And we have with us today.
My name is John William Sidhom. I'm my last year medical school at Johns Hopkins.
And what we're going to do is we're going to pick up on our conversation from the last TPG, where we were talking a little bit about how Bayesian theorem, how Bayes theorem, how Bayesian inference comes in and helps us do our job as clinicians in the hospital. I'm going to let John recap what we talked about last time real quickly, and then we can jump into some really exciting tools that we have set up for folks to test out and tinker with their own understanding of what Bayes theorem is.
Sounds great. So last time we met, we had talked about a paper by Dr. Reza Manesh called "Don't Drop the Anchor." This paper, and I'm going to pull up a notebook just to kind of just what I'm alluding to here. But so this paper, really briefly from last time, had a clinical scenario where a patient presented with a high suspicion of pancreatic cancer, and they ordered two tests to help them decide whether to do the Whipple or not. They applied Bayes' theorem to these two tests. One was a CA19-9 and one was an FNA biopsy. And Dr. Manesh walks through this scenario with Bayes' theorem, and they show that, very interestingly, what began as someone with high suspicion of pancreatic cancer, when you apply Bayes' theorem on these tests, you find that it really shifts your posterior probability or your post-test probability, whether that patient has cancer. In the paper, they deemed that the risk of cancer or the cost of missing cancer was so high in this case that they went through with the Whipple anyway. That did confirm that it was not pancreatic cancer, but it was a beautiful clinical scenario showing how our beliefs can really change through the workup of a patient. And how do you formalize that decision making or that inference process with Bayes' theorem? So today we're going to jump right into what is Bayes' theorem and how can we use it in a practical setting. So Avneet, I'll turn it over.
Just as a quick recap, let's talk real quickly about what Bayes' theorem is. Bayes' theorem, sometimes called Bayes' law. Bayes' theorem is a way that we can try to formally use data to change our beliefs. And when we say beliefs, we mean that in a scientific way, a hypothesis. We're coming in with a hypothesis that we can test and change with data. So Bayes' theorem, simply put, it's daunting, but that equation is really only four pieces. The first piece is the probability of theta given x, which another way of saying it is the probability of the disease given the symptoms that we see is equal to the probability of x given theta, or the probability of symptoms given the disease. Those are two very different things from probability of theta given x and probability of x given theta. Now you take the probability of the symptoms given the disease, multiply it by the probability of the disease. Just what is the probability of the disease? It could be your prior belief in that disease likely happening, or it could be your prevalence in whatever city you're in. That P of theta captures how before anything, your prior thought of what the disease is goes into your P of theta. Finally, it's all divided by the probability of x. X is your data. And so this is trying to capture the probability of you seeing the data that you saw given the full space of anything, of any model, of any reality. What's the probability of this data given all possibilities that generated it? That is a deceptively hard number to calculate. It's actually really, really, really tough to calculate. And using more modern tools and computers, we can try to calculate it. We can actually use models to come in and try to calculate what P of x is. And P of x is called evidence. And that model with your data is always what evidence is. Or we can take a different approach. And this is what we end up doing in medicine. We come in and we say, you know what? I only really care about one disease or another disease, or one disease and health. So if I can compare my P of x given disease with a P of x given health, I can actually, using a trick of division, ignore P of x. You can just do P of x given theta is equal to the disease you think, over the P of X given the disease is not there. And that is something we call a likelihood ratio. And so likelihood ratios and working with likelihood ratios are starting to enter the picture of how we do medicine. And it's really just the first step in this larger effort to start thinking like a Bayesian. And for that, we have these amazing tools now available to us through open source code and through Python and through these tools that help us actually work through the calculations that are related to likelihood ratios, but also to Bayes' theorem and even beyond that, which John will kind of walk us through for the rest of the notebook.
Yeah. So maybe just to summarize kind of what you said, so I understand it as well, is the Bayes theorem, why it's hard to implement is this P of X, this evidence term, is our data as seen through the lens of many models, right, under all conditions. In medicine, to simplify this, we look at P of X in relationship to two models, and that becomes our likelihood ratio, and that allows us to transform this into this form that uses odds instead of probabilities, and then uses a likelihood ratio instead of exactly this whole block there. And that's kind of, did I capture it there?
Absolutely.
Okay. So what we're going to do is, so something that, when I was starting medicine, and I was hearing the words applying Bayes theorem and then doing Bayesian inference, I kind of thought they're one and the same. I think what's surprising to me, I learned, is Bayesian inference does not mean using Bayes theorem. They're actually, it's a little bit of there's some conflation, unfortunately, with how the terms are used, but Bayes theorem is not Bayesian inference. So what is Bayesian inference, right? And if you notice something here, we're going to first do Bayes theorem, and then we're going to get to Bayesian inference. And we want to highlight in this notebook and to this session, what is the difference between Bayes theorem and Bayesian inference. So let's first just kind of do what they did in the paper. So we'll do this programmatically. If you remember in the paper, they gave a prior belief of the pancreatic cancer after the clinical presentation being 0.9 or 90%.
So if I'm understanding that correctly, they did a whole bunch of tests. They kind of tried to treat the patient, and before they did the real meat of the paper, they came in with it with a 90% chance certainty that it was cancer.
Yeah, so the clinical presentation, right, was very compelling for the symptoms that were presented, the social history.
Gotcha.
All these were very consistent with a very high probability of being pancreatic cancer.
Gotcha.
So 90%, right? We'll start with that.
Pretty high, yeah.
Pretty high. We'll compute the odds, and then in the paper they cite that the likelihood ratio they used for a negative test was 0.25. Okay, so when we plug that in and we apply Bayes theorem once, we get that after the CA19-9 test, our probability now is around 0.7, 0.69. So definitely, it's we can see why they didn't stop there, right? A negative test in this patient with a high pretest probability for a test that has an LR of 0.25, right? It's not 0.01, right? That's still 1 in 4 you'd be missing, right? False negatives. So they do a second test that is an FNA biopsy. So that's fine needle aspiration of the met, and they look at the cells under the slides, and if a pathologist will read that as cancer. Now, because an FNA is not a whole biopsy, it's guided through ultrasound, you can still miss cancer. So there, while it's a better test than the CA19-9, its LR is 0.11, definitely better. It's by no means a perfect test. So if we apply Bayes theorem again, we come to a probability of 0.19. So given the high prior belief, given the symptomology and the presentation, with these two tests, the post-test probably was still 1 in 0.2. It's 1 in 5, right? It's not off the table. Maybe we can talk here about, in the paper they do the Whipple procedure, they get the full biopsy. It is not pancreatic cancer. And I think this is where we can have a small discussion about what it means clinically
Yeah.
to use these probabilities, right?
Yeah. So what do you think in terms of you're starting out with a 0.9? You don't really want to do a Whipple. So you do a few more tests, and those tests turn out to move you in a direction that says actually the Whipple isn't necessary, right? It's not cancer.
Yeah,
And you come down at the end to about a 20% chance that it's cancer, given these things that you've seen and given you came in confident. What do you do? How
yeah.
do you, what other factors are missing from this? Because I think what we'll see is Bayes' theorem gives us a piece of the bigger puzzle, but it doesn't give us the full picture. We need something else to actually make that final decision. What's that piece that's missing?
I mean, you talked about this last time, Vineet. We talked about the values of the patient, right?
Mm-hmm.
What they value. Do they have grandchildren? Um, I think, there are patient-specific factors
Mm-hmm.
that have to come into account. The person's general state of health. Can they tolerate a Whipple, right? What is the operative mortality of a Whipple procedure in this patient, right? Um,
It goes into it almost goes like that's the risk stratification portion of this picture. How much are you willing to risk? Is 20% chance of
yeah,
something very, very, very bad happening acceptable? Well, it
yeah,
depends. How bad is bad? Is it a 0.2% of something very, very small happening? Yeah, yeah. Why would you not take that if the benefit of
exactly.
not doing it is pretty high? So those values exactly come in, and nothing that Bayes theorem or even Bayesian inference, they don't give answers to what you should do,
Yes,
because what you should do always incorporates information from what the patient's values are and from factors that might be really tough to quantify. So we're here at 20%. Is it a very certain 20%? Like, yeah, it's 20%, and that's, I'm sticking to it. Or is it a loose 20% of it's 20% based off of these tests, but there's a chance that it could actually be really high, that there's a really high probability that it's actually there, or it could be even lower. These kind of questions we're now equipped to answer a lot better because we've kind of walked through the math of it.
yeah,
What are kind of next steps? How do we make that next leap into
yeah.
we need more information to actually make some decisions?
So I think what is missing, and you kind of alluded to this, was what is our certainty of these numbers, right? How do we quantify uncertainty? And I think that is what really defines, or what is the main benefit of Bayesian analysis, is that Bayesian inference and Bayesian analysis attempts to quantify the uncertainty of the model, right? And of the model's outputs. And that is what is missing in this preliminary analysis. We don't understand, we have no way of encoding, well, how certain am I that the test is this good? Or how certain am I of my initial prior belief? And that's kind of what we're going to go into next, is
Mm-hmm.
we're going to use a software package called PyMC3. It's a probabilistic programming package that allows us to build, train and do inference with probabilistic models. And will allow us to actually, we're going to take the same exact equations, and we're going to just represent them in a probabilistic framework. And we're gonna bake in our uncertainty into our model and see what comes out. Does that sound like something worth doing?
Absolutely, let's do it.
So first, with every variable, we have to replace every variable that we had as a point number with a distribution. Okay, so we're gonna say, so first thing we're gonna start with is our prior belief that it was cancer, right? So we know that the authors said 0.9. Their mean was 0.9. But we want to actually represent it with a whole distribution. So we're going to use a beta distribution. The reason we're using a beta distribution is because it is constrained to values between 0 and 1, like probabilities are. And what's interesting here, just keep in mind that we are actually, it's a little bit meta, but we are actually showing the distribution of probabilities, right? So there's like a probability of a probability that we're trying to say, right?
That's a common theme in Bayesian analyses. We're not assuming there's a true parameter, that there's
Yeah,
this magical parameter out there that is solid that we're trying to go find. We're always, always, always trying to accept that we can't fully know things, which means we're doing distributions on distributions on distributions.
exactly. A lot of exactly. We are chain, but this is the idea that ultimately that when the Bayesian analysts want to say, can we make decisions even when we don't, even when we're not sure, right? That is the goal. The goal here is not just to pontificate on how uncertain we are.
Mm-hmm.
The goal is, can we still make decisions when we are uncertain? How do we formalize that process? And that's what we're doing today. Whereas we're going to say, even when we're unsure, we can still make well-informed decisions. And that's what it's, as doctors, right? It comes down to, what am I going to do for the patient? Yeah. Am I going to get the Whipple? Am I not? Those kind of things. So we're going to start with that for our likelihood on our prior, because it's constrained appropriately and it makes sense. Then what's more interesting here is the CA19-9 test, right? In the paper, they give us a range for sensitivity and specificity of 0.7 to 0.92. Now in the paper, they take an average of 0.8 and they compute a LR of 0.25, and they use that in and that's what we did earlier. But now with a Bayesian approach, we can actually say, let's put the whole range into our model. Let's say I'm not sure if it's 0.7, I don't know if it's 0.75, I don't know if it's 0.92. It's somewhere between there, right? So we'll use like a uniform distribution that says that the probability of the LR is between these two numbers. And we'll put that into our model and say, okay, we've baked into our model our uncertainty of how good the test is. Because the CA19-9 test may have, maybe if it's made by this company or that company, it just operates differently, right? They use different thresholds, et cetera, for a positive test. So we will bake that uncertainty into our model. And then this allows, so this model you can play with, you can actually, this line of code here, you can actually run yourself and you can change certain parameters. The two things we're going to play with today are going to be which prior distribution. So we're going to first use the beta one, and later we'll use a different one. So we'll say we use a beta distribution here, and we'll start with that. So we'll run the model, we'll build it, and we'll look at it really quickly. So the model will apply Bayes theorem twice. So initially we will come in with a distribution of our prior right here. Our prior is right here actually. Yeah. It will get converted to our odds ratio. We will take our sensitivity. We will compute a likelihood. We'll apply Bayes theorem once. We'll apply Bayes theorem again to get our final probability. Now for the FNA, for the purpose of this discussion, we're going to assume 0.11 is the likelihood ratio, and we're absolutely certain that is what it is, right? We had not put in any uncertainty on that number, but we could have represented that with some distribution. So just to recap, our distributions that we're using a distribution on the prior belief, and we are using a distribution on the likelihood ratio of the CA19-9 test. Mm-hmm. And we're going to put that all into our model, and we'll see what comes out. So this is the first thing we're going to look at. This is our prior belief, right? So we see that the mean is around 0.9, and this is roughly where we say, well, we think this is a high probability of cancer, and we're pretty sure of how sure we are about that number, right?
Yeah. So what would that look like if you were a little bit less sure that it was 0.9?
So we may have actually maybe a longer tail, right, or a wider variance here, right? We could represent that as being less sure. But this is kind of where we are right now.
So exactly. This tells us there's a 90% chance, and that's a pretty solid 90.
Yeah, and we're pretty sure about this number. And then the likelihood is going to span this range of like 0.1 to 0.4. This tells us how sure we are that when the test is negative, that you have ruled out disease. Still quite a large range. Even though an LR the mean is 0.25, the range was 0.1 to 0.4, and then when we apply Bayes theorem once, we'll get the posterior distribution, the post-test distribution after one test. And what we see here is we still think it's pancreatic cancer, given how sure we are before, but now we're actually less sure. We have a negative test. So now we're starting to move our belief away from pancreatic cancer.
Not only does the peak move a little bit lower, so you're now kind of 70% sure, but of that 70%, you're also a lot less sure. Your tails go wider. And
exactly.
I guess that's the difference between this approach and a post-test probability. In a post-test probability, it's give me a number, right?
Yeah.
And my numbers here would be 0.9 down to 0.7. That's my pre-test probability. That's my post-test probability.
Yeah.
But what we're doing here seems like we're actually also encoding this extra little bit of confidence into the picture. And
Yep.
what that cool curve is showing is, wow, you came in at 90%, but this test that does decently well kind of is really surprising. It's a little surprising.
Yeah.
So let's open up the idea that it's actually low, but I'm still going to try to stay up
Exactly.
near 90
Yeah.
as
I think
much
that's
as
a
I can.
great point. A great point is with our prior method, we only know the probability. We do not encapsulate the variance or the uncertainty
Yeah.
of that number. And that's what this framework allows you to do. And we can really incorporate uncertainty everywhere, right? You know, here we've done it in our prior and we've done it in our test, right? How good our test is.
Yeah, you might hear the term point estimates. So we're not doing
Exactly.
point estimates anymore. We're trying to look at the full probability over everything that's possible instead of just the one thing that is most possible, which we may not know.
Exactly. And then finally, to look at, we apply Bayes' theorem again, and now we have our prior, right? We have our post CA 19.9 probability, and then we have our post FNA probability. So the FNA has a much lower likelihood ratio of 0.11, right? So it's a better test.
Mm-hmm.
And when you combine these two tests, when you put them together, now we
They synergize.
Exactly. There's now we have two orthogonal tests that are both telling us the same story, right? So that
When
really
you say
pushes.
Orthogonal, what do you mean by orthogonal?
As in they're independent tests, right? You know, one is a tumor marker in the blood, and one is a biopsy of the tumor. If they both say that there's no cancer, you know, there's some consensus, right?
Mm-hmm.
And that consensus helps us believe that it is not cancer.
Mm-hmm.
And so we see that the synergy plays out here, and we see that the final probability, yes, the mean is still around 0.2, but the distribution is still fairly wide, right? If we put a 95% confidence interval, we're going anywhere from 0.05, 0.01, all the way up to around 0.4, right?
Mm-hmm.
So pretty sure we're not at 0.9. Like we moved it down, so we're not there. We don't think the true probability is at 0.9. But the question is, and this is, we don't have to go into this again, but this is where the clinician can look at this now and say, how do I relay this uncertainty to my patient, right? How do I say, like, this is kind of where we're sitting right now. It's 0.2, but this is what it could be. It could be anywhere up to 0.6, right? So, and this is where a discussion clinically happens, right, with the patient, and where you begin to incorporate the values of the patient into play, and that it becomes a more personal decision-making process. But I think when we as clinicians begin thinking this way, right, we can begin to, I think, do better by our patients.
So one strength of this approach that strikes me is we can separate the two pieces that physicians always struggle with. One is what's the disease that I'm supposed to treat, right? Like that's the goal, is figure out what the disease is. What's the probability this is a heart attack? What's the probability this is pancreatic cancer? I just need to know that. But there's another probability, which is what's the probability that this lab value was switched with someone else's lab value? Or what's the probability that this image was actually swapped or blurred or something? Because those are two different uncertainties, right?
Yeah.
So you may not want to go to a patient. It just occurred to me when you were talking. You may not want to go to a patient and be like, there's a 20% chance that it's there, but there's also a 60% chance that it's there, right? So you have to be careful with probabilities because there's an old movie that 60% of the time it works every time. It was a joke, but in many ways it's actually a very Bayesian thing to say. This is perfect as a tool to help us on the physician side capture the complexities of being a physician, which is there's just uncertainty about what we're supposed to treat, but then there's also uncertainty about how much do we trust measurements when they go against what we know is kind of there, or when they don't go against what we know is there.
Yeah.
This is a formal way of kind of splitting the two, but then using both of them to give you a single shape that should help you make a decision. That thing is not at 90%. It just isn't at 90%.
Yeah.
It's down near 0.2%, or sorry, the 20%.
Yeah.
And now you can do the patient values, and you can do the bigger conversation and say, is 20% just too high?
Yeah.
Given the cost of a whipple,
Yeah. And notably here, you know, 0.2 is about the same place as 0.9 in terms of certain which side, right? But as we said before, while we have a huge change of probability, we are actually more unsure here than we were here. We were pretty sure how the patient presented, and you know, we were just like, it made perfect sense. So even though now we're at 0.2, we're at 0.2, but we're less certain, right? Yeah. Which does give credence to the Whipple, because you, at that point, the benefit of catching a stage 1 cancer is really high, right? Exactly. And we are not very certain of our 0.2, right?
So one interesting thing would be in that prior, you're 90% and you're pretty sure, because that's a patient you just worked with. You just talked to them.
Yeah.
You spent some time with them. There may be other tests that were incorporated to get to that 90% confidence. What would happen if it was just a patient that came out of nowhere? A patient that just comes to you and says, hey, I have a problem. And you decide that this test is something that you want to do. That's a very different prior situation. You're walking into the room in a very different situation. How do you deal with that?
Yeah. So we can do that in our model. We can go back and let's say we were to take our test, these tests, and we're going to run them on somebody we just randomly chose on the street, right? We could say is, knowing nothing about them, we could change our prior belief they have cancer to a uniform distribution across 0 to 1. All probabilities are equally likely for this patient. So we do that by just changing this one line of code here. We'll comment out this line and replace it with this line. We'll rerun all below, and we'll see our results. I'll give that a quick second. Okay, voila. So to recap, our prior probability now is uniform across 0 to 1 because this is somebody random on the street. Our test has not changed. It's our certainty of our test. But now our posterior after that test looks very different than the patient that came in with that very strong clinical presentation. And we see here that someone with no reason to believe they have cancer with a negative test, right, pretty much rules it out of this patient. I don't know if you want to.
Largely because one point here is in this is very noticeable in Bayesian approaches. If what you're coming into the picture with isn't very informative, you're pretty much going to put all your marbles on the tests that you do, on the data. So if you have no real good model, no structured reason to think something, then whatever data you can get, you're going to put a lot of credence on that, and you're going to go with what the test tells you to, because you don't have anything else to go off. Which is kind of what we're seeing here. P2, the kind of posterior distribution, is pretty much just the distribution of the test, and the test is negative, so you're gonna push everything down to 0, and the patient is just, it could be anything. And if you had a little bit more information about that patient, which we just did, we did a whole thing with 90%, that's information. That same test result has a very different outcome, because it's just, you're dealing with other information now. So the data comes in, and the data helps modify your idea of what's going on. It kind of goes back to what I said, what we talked about earlier. Evidence and data are different things. Data comes in, it just is. But data in the context of your model is complicated, and Bayes' theorem helps us try to work through that, not only with just numbers, but with distributions. And that's kind of what we're seeing here. We can come in a situation where we know nothing and formally, systematically update our belief from data, or we can come in with a pretty clear idea and systematically, formally update our belief.
Yeah.
And that's the strength of it. I think it gives us a way to formalize what physicians already do
Yeah.
very well, but bring in math to help us do it better.
Yeah.
And that's a really strong. This is a fantastic notebook. It really kind of outlines so many facets of what gets some people excited about Bayes' theorem and Bayesian inference.
Yeah, I mean, like we could only. I think this was a really fun for those who are watching. This notebook will be. We'll put the link in the description of the video. It'll be on our Twitter page. It's all on GitHub, and I think we probably can get a collab up. Hopefully, that can help us run it live.
So
But
that
if
was
you
a
need
lot
to,
of tools just thrown out at people.
yeah. Oh,
Just
yeah.
look below, look like
Yeah.
down there at the
For all
link,
this.
and we'll kind of have the main things so that you can come in and start tweaking with this,
Yeah.
and start fiddling with this notebook and test your own Bayesian intuition.
Yeah, and we hope that of course, any feedback like in terms of things like this, is this helpful? Was it too complicated? Was it would you want to see other examples of using PyMC3 in clinical kind of examples? We would love to do that as well. But this is all here for you guys to play with. Hopefully, moving forward, I think as clinicians, I think maybe the next steps for us just start thinking, how do we take, what is this math, and then how do we begin to bring that into our daily decision-making processes in a way that is seamless. I think that's maybe for future discussions, how we could do that.
Yeah, well, one thing that this paper really was really helped me understand was how in the course of our clinical decision making, for the most part, going into the nitty gritty numbers of Bayes' theorem doesn't really help. Just getting a broad view of, is it likely, is it not likely, is it somewhere in the middle, kind of helps for the most part. But there are certain cases where it becomes really complicated when you're so certain and the tests just keep coming back negative, but there are these costs associated with decisions. There's kind of formal ways of doing that. And I think that's a really exciting future that physicians have in front of them. How do you use tools that sometimes leverage Bayes' theorem, sometimes leverage deep learning models? How do you use these tools in a way that complement your physician's intuition, not replace your physician's intuition? You want these tools, I think I said this last time, you want these tools to provide you better priors. You don't ever want them to provide you posteriors. Your job is to take the prior, take the patient, and make the posterior. And how can these tools actually help us as physicians do that? It's an exciting world, and we'll for sure undoubtedly tackle that in future TPGs.
This was a pleasure.
As always.
We will see you guys next time.
Sounds good.